So welcome. Today, we are going to talk about treatment planning in marriage and family therapy, although the principles we're going to talk about actually apply to all of the mental health disciplines. And this is something certainly that you hear a lot about, but it's funny how little training we get on it, isn't it? And so I'm really excited to be talking with you about this. When I first did my training, I remember when I was told to write a treatment plan, like, I don't know, it was my second placement. It wasn't the first, just so you know. Second field placement. And I remember the supervisor, she was kind of intimidating, and she told me to go write a treatment plan for one of these cases. And I had never heard, hardly knew what it was, hadn't done one at my last site. They never talked about it in grad school, and I really didn't know what to do. So what I did is I remember sitting in the lunchroom, and I got a stack of all of the files that were transferred to me. And I went through and I looked through all of the treatment plans that the other therapists had created. I'm like, oh, okay, this is what they're looking for. And but it was like this secret, I think there was a lot of shame involved. And so that's how I started writing my treatment plans. And then fast forward, I get my degree, I come out to California. I got my degree in Texas. I came out to California. And in California at the time, this is back in the last century, folks, you had to do an oral exam. And I got my license as a MFT in California with an oral exam. And part of the oral exam was to give a theory-based treatment plan. Well, here's the kicker. There was like nothing in the published literature about a theory-based treatment planning, which is where all of my textbook series started from, because here I was, this professor, and I was supposed to be preparing my students for the California oral exam that required a theory-specific treatment plan. And there was like nothing. I mean, and I'm an academic, so I literally would go into the databases. I owned all the books. I'd look it up in every, index. I mean, I scoured the literature, try to find a structural family therapy treatment plan before my first book. It didn't exist. A strategic one. Well, they just were not published. They were something you found in a file someplace, but no one wrote about it. So that's actually where my whole textbook writing career came from. And so there was a bit of a trauma in the beginning for me learning treatment planning. And then when I came in, I was supposed to like magically teach people how to do it without any published research resources. That's when I said, we need a book that has this in it. So you'll notice I have lots of treatment plans in my books. I'm very passionate about this subject. And but it was really a lot of desperation and difficult times that brought me to my interest in the subject. So let's go ahead and get started. And because today what I'm going to give you is just a broad overview about what the heck treatment planning is, and then some really core tips and practices and just key things to keep in mind when you're developing treatment plans, regardless. And we'll talk about there are different types of treatment plans out there in case you didn't know. And so, but these are just some really core principles that should give you a very solid foundation for both doing what I would consider an academic treatment plan, and I'll go over some of the details of what that is, and also what you'll be doing in your practice sites. So let's get started. And as we're going through this, if you've got questions, you can also put them in the Q&A, and I'll try to answer those as we are going along. So for those of you who are attending live, not watching this replay on YouTube, you can get a letter of attendance, but you have to wait till the very end of the session. We will give you a link. And this is, unfortunately, you can't email in after the fact. You're going to have to wait. I will do my very best to end exactly on the hour. And so you'll get a link, and that's how we will be giving out the letters of attendance. If you are watching this on YouTube and wish you could have got one, you can register for upcoming sessions, therapythatworksinstitute.com/YouTube live. And we continue, I do one a month, and they are typically during working hours. I will admit that, so that's the challenge. But if you are at a university that will accept a letter of attendance instead of a CE certificate, these are not CEs. It costs money to actually offer CEs and offer that. And actually all the letters of attendance, we were getting so much, it was costing us a lot of money to issue those after the fact. So we're just giving them live. So you have to stay till the end. I will put the link up and you will be able to get your letter of attendance, which is not a continuing education credit, but many universities will accept those as part of their, outside training that's required for the program. And you will get that at the end, but you must stay till I put it into the chat. You'll get a link there. Okay. Awesome, awesome. And like I said, if you want CEs you want these letters of attendance in the future to just to attend these live where you can ask me questions, it's at the therapythatworksinstitute.com, and there is a YouTube live page subpage there. You'll find it on the homepage, or you can just type YouTube live, and the future trainings will be posted. Okay. So treatment plus plan. I remember when I was sitting in that, break room trying to figure out what the heck a treatment plan was. Like, okay, treatment is something you do. There needs to be a plan. What the heck is this thing? So, it's really a plan to address whatever the identified problem is for your clients. And at this time in history, I would say that they're pretty much ethically required for just, or required in general of all mental health professionals. Now, what exactly that looks like, there's huge variety, extensive. I mean, it is extreme. You can have a treatment plan that is basically 2, 3 sentences long. You can have one that is pages long, right? So there are lots of different types of treatment plans, but it's all basically, the concept is this is your plan of how you're going to address the client's presenting problem. And now I recommend that you do this if possible, if your agency or third-party payer allows it. You want to do it after you do your case conceptualization and a clinical assessment. Most agencies and insurance companies will expect some form of treatment plan after the first session, sometimes after the third session. Somewhere between the first and third is pretty standard. And case conceptualization, I have another lecture on that. Clinical assessment, I have another YouTube lecture on that. And today we're going to take, when you've done both of those, you use those to inform the treatment plan. And so one of the things that is really what I think is critical in mental health, and I'll be talking about this throughout the training today, is that you want, as a mental health professional, you want it to address theory. And you want to also, when you're putting the treatment plan together, you should be thinking about which theory or approach that best fits the client and their presenting issue. Should be evidence informed, of course. I have a whole other lecture on that. But so this you want to be thinking about, when you're putting the plan together, what theory, what model, what evidence are you using to create this treatment plan? Now, do we really need these treatment plans? If you haven't noticed yet, life often does not go according to plan. And I can promise you, if you are new to this field of mental health, that, psychotherapy, family therapy rarely goes according to plan either. But that's okay. It is still very important to have a plan. And there are lots of reasons why. To begin with, it helps you structure treatment. It gives clients a sense of hope. And we know that, they have to have hope that you're the right person with the right method to help them. That is as important as whatever treatment model you're using, whatever evidence you're using. So having a plan to structure treatment makes it much more coherent, makes client trust you. It helps you be organized. It helps you show up and at least, show up with more confidence for sure, and to have a plan. Now, oftentimes things happen between our sessions, right? And, clients come in with a different topic than maybe we talked about last week and a different set of problems, and life happens to them. And so we take a hard right turn, right? You have to be ready to pivot all the time in this work. But having a plan makes you confident. It helps you be more organized. And it helps you know whether or not you're making progress, right? And you're going to make better treatment decisions when you have a plan. So when you sit down and go, okay, I did my first session with this client, what am I conceptualizing? What's their diagnosis? What does the research say is the best thing? And you think through it. It helps you think through things, right? And believe it or not, it actually, having a plan helps you plan for the unexpected. Because sometimes, if you actually have a strong conceptualization, even the quote unquote unexpected events are going to link back to core dynamics, which we will be talking about, those core dynamic issues that you're working on. Yeah, maybe we started talking about it at work, but if it's a core dynamic, like let's say there's some boundary issues, right? You're going to see it at home, with their spouse and with their children. So so having a treatment plan, having thought through what the client's saying the issue is and putting some plan together is going to make you much more confident when it's time to pivot, much more confident when a new crisis comes in, because at least you have this plan, you know where you're going, you know what the core issues are, and that makes it actually easier to respond to the unexpected. Let's do a very brief history of treatment planning. As you know, in the beginning, there was nothing written. But historically, treatment planning was very much based on a medical model of treatment planning, which is very different and in many ways kind of useless to us in mental health because they're very much symptom based. There's something like reduced depressed mood. I mean, for the love of God, you don't need 3,000 hours and a master or doctorate, right, to know that if someone's saying they're depressed, that the goal should be to reduce depressed mood. Like anyone off the street can tell you that would be a goal. And in medicine, those types of goals make more sense and are more clinically useful, right? But in psychotherapy, they don't mean a whole lot because we have literally 500 different theoretical models, each of which has at least 10 to 20 different interventions for reducing depressed mood, right? So reducing depressed mood is like, yeah, and how is really the question. So that you can be doing that through couples therapy, family therapy, individual therapy. There are literally thousands of ways to do that. You still haven't, you have no idea what the context or what the heck that really even means. So yeah, and you will work at some sites and some insurance companies. All they want is this medical treatment plan, which is reduce depressed mood, reduce anxiety, maybe reduce conflict with couple and family. Okay, like that is not useful to help us conceptualize what we're going to do in session. Okay. So, yes, you will be doing some of these very medical model treatment planning approaches that are just simply reduce the symptom, which I think makes a lot more sense in medicine. And insurance companies, since they're taking in, thousands of different treatment plans from hundreds of different types of providers, that's all they want from us. Okay. That's all some of them want. And you will work in agencies and for third-party payers where all they want is reduce depressed mood, reduce anxiety, reduce panic attack, you know. So it's easy, it's mind-numbingly boring, but it may be all you need to get paid. Okay. Not clinically relevant. What you're going to find more clinically relevant are theory-based treatment plans where you have goals that are addressing the core psychological or relational dynamics, right? So if someone's, let's say they are depressed because of negative self-talk, well, then you could be reducing negative self-talk, right? And that's going to affect the depression. It gives you a focus for treatment. You know what you're doing, right? That's, CBT and you're reducing, whatever, negative family schemas, negative self-talk. Okay. Now you have a plan that's relevant to you when you sit down with your client. You can also have, you can be depressed because of, let's say, blurred boundaries, so you can have, to the goal or treatment could be to increase boundary clarity, and which would have the effect of reducing depression. And then when you put all that together, you're going to have what I call a clinical treatment plan, but that's where you're combining both some theoretical concepts. So you really have the treatment plan actually gives you something useful, as well as the diagnostic piece of reduce. So, such as addressing the clinical symptoms, that's what the third-party payers pay for. So you're reducing, for example, enmeshment or negative self-talk to reduce depressed mood. So now you have a much clearer focus about what the heck you're going to be doing in that room. And certainly in your training years, you want to be doing this type of treatment planning. A, it's going to help you pass your licensing exam. If you are listening to this and have not passed your licensing exam, you need to do theory-based treatment planning. That's why I started writing all these books, was to help people pass their licensing exams. So understanding that, but it's going to make you a better clinician to be thinking using your intervention theories, your clinical theories, as well as connecting that to your DSM symptoms, because that's what we do, as psychotherapists, family therapists, is reducing those symptoms, is several steps removed from what we're actually doing in session. Okay. Okay. Um, let's see. Oh, someone's asking about creating treatment plans and case notes on AI. Okay, I'll go ahead and take this. I know we're kind of early, but I will. It's a great question. In a quick, here's my response. And I do have a class, a different course that's called the 2-minute treatment plan and progress note, which is not a theory-based one, but it's a very practical one when you're seeing 30 clients a week. I highly recommend my 2-minute treatment plan and progress note course. But so here's what I will say. If you're in private practice, there is no reason to, in my opinion, to be risking your client's confidentiality because they have to sign off and agree to have the sessions recorded by AI. So you can't just do this without client, agreement. And as someone who works in private practice, it's not justifiable. You can do a progress note in 2 minutes. You can do a treatment plan in 2 minutes. Okay. Why risk client confidentiality in a private practice setting? I don't think it's warranted. However, so that said, and also because when you write your treatment plans, you're remembering, right? When you do your own progress notes, you're remembering. I don't know how I would remember what my client said from week to week. And a lot of therapists don't remember my clients have told me, wow, Diane, you've got a great memory. And, you know, and I actually teach in my therapy that works unifying framework. I teach how to create these, in your head movies so that you do have a great memory. So having a great memory of what your clients say week to week, and most of my clients come every 2 weeks, and the ones that come every month, that gets a little tougher sometimes, right? So writing it down helps you remember, and actually writing the treatment plan down helps you remember the core dynamics, which we'll be talking about. On the other hand, if you are working in an agency where many of my students go and work in a county mental health agency where they see 25, 30 clients a week, and they're doing over 20 hours of progress notes per week because the county has these progress notes and treatment plans that go on for 4 pages, right? That is where AI is appropriate, okay? People are getting reduced cost services. And there's a mountain of paperwork to get those services, and that is where AI is appropriate. So it really depends on your context, what type of documentation is required for you. But I think someone in private practice who has minimal requirements, you're doing this to protect your license pretty much. No one comes in and reviews my notes as a private practice clinician, then I don't think it warrants risking my clients' well-being and their privacy by putting all of this into AI where we still don't, know where it all ends up. We do know that there are multiple authors and publishing houses suing all the different AIs for cannibalizing their works. So AI is still, all of those laws aren't even clear, but I don't want any of my transcripts of my clients in an AI, even if they take out the names, quote unquote. So I have an opinion. What do you think? Alexandra, I hope that answers your question. Um, do I use the Wiley treatment planners? No, I do not. I use my 2-minute treatment plan. So in all my textbooks, you will learn you will get all these theory specific treatment plans. And so use those for your course assignments. In my private practice, I have a 2-minute treatment plan. I have a course on my website called the 2-minute treatment plan, and that's what I use. And I've created a unifying framework, and there are 2 goals that I think everyone needs. It's a whole other workshop I do, but I keep it super simple in my private practice, and I think it makes me a better clinician. Okay. Are you able to print the slides? No. And we're working on finding a way because everyone asks every month. So I think in my If you ever register for my Laugh Your Way to Licensure course, I think everything's getting posted up there in kind of a bonus section. Um, so, but we don't have a way to get it distributed to folks on the YouTube platform. And also, I have a Clinician Connection membership thing where it's also there for download, but we don't have a general audience way to do that. Okay. Oh, what are your books on MFT theory you'd recommend to start with? I recommend Mastering Competencies in Family Therapy, fourth edition. You can only buy it from Cengage. I would buy the hardbound book. And it is a lot, but I've had people refer to it as the Bible. Some universities, the students refer to it as the Bibles. Other people have referred to it. One school told me they call it the cookbook. So when you arrive, I can't remember this university, when you got to get the cookbook for family therapy, which is Mastering Competencies. And that really, a lot of universities do use it across multiple courses. And, the truth is I still use it as my own reference manual. So, and this lecture is designed to go with that book. Don't ask me the chapter. Yes, Shannon's asking, do you have a book that encompasses all of these to help with passing the national exam? Yes, I do. Mastering Competencies in Family Therapy, and I would get the fourth edition, and unfortunately, you can only get it directly from Cengage.com. They like broke up with Amazon. I'm not real happy about this, but that is the fourth edition. Does have all the new stuff because I'm not updating editions very often, and all of these lectures are designed to go with it. Okay, awesome. Lynn is saying it's a great book. Thank you, Lynn. I appreciate it. Okay, now back to our regular um, systems, regularly scheduled a workshop. Oh wow, hi David. He's in systems at CSUN where I just retired from CSUN. I've heard that some people are like, when's she coming back? Hi David. I'm just saying hi. Awesome. Thank you, Shannon. Put it in the sorry, I'm talking to Cengage about why they took it off of Amazon. It's so bizarre. Anyway, that's another lecture. Here we go. Let's keep going. So, in clinical treatment plans, and so these are long plans that they are treatment plans with training wheels. They are longer than you will probably use in practice unless you end up in a county agency, which many of you will because the pay is better there. But we'll go through this step by step. But there's an introduction that's going to just what theory are you using, what modalities. And then you go through the plan with interventions, and we're going to really target dynamics that we want to increase or decrease. So the dynamics could be negative self-talk, boundaries, that sort of thing. Now, the treatment tasks, I put in here because these are more something that I use in an academic environment. And I think in the first few years of training, this is good for your licensing exam. But these are just treatment. These are things that you should be doing in the various stages, like creating a therapeutic relationship, developing a case conceptualization, identifying crises and referrals. So these are treatment tasks. In my very first treatment planning book, it's theory-based treatment planning and marriage and family therapy. I combined these two, and I realized when you went to go write a plan for insurance companies, the treatment plan tasks got mixed in with a true clinical goal. So I separated them for the last 20 years or so in my more modern textbooks. But these are really helpful for when you first start your first few years and for licensing exams to understand what's happening in each theoretical approach, because some theories have very clear interventions that are used, let's say, to do case conceptualization, in a particular approach. So like in solution-focused therapy, the miracle question is part of the case conceptualization, right? Or a genogram in intergenerational psychotherapy. So there are certain tasks that there are actual interventions that are associated with them that are good to know. So that is what the treatment task is. I've added diversity considerations. And again, this is more of an academic thing. You'd never submit something like this to insurance. But it invites you to think about social location when you're putting your treatment plan together. Does this make sense for this client based on who they are in terms of age, race, gender identity, sexual orientation, language ability, right? Education level, neurodiversity, all those different things to be thinking about. And then also evidence-based practice. So, what does the evidence, does your plan make sense given what the evidence says? So this is a very comprehensive plan. I will tell you where you can download them from my Therapy That Works Institute.com site on the books page. You have to put your name and email in. I will just send you updates when I update them, but you have access to all of these forms as well. And then there is a place also for the client perspective. Have you thought about, from your client's perspective, do they even agree with what you are saying? Awesome, awesome. Okay. Very cool. Okay, I'm getting some notes. And David, who's at CSUN, saying that everyone misses me. I kind of I miss the students and I miss the faculty too. But then I get to do this. So, I don't miss the CSUN bureaucracy, but I don't think anyone would. Awesome. And Shannon Hanks is saying that they're a psychology adjunct professor and you share all this with students. Yay! I hope so. Hopefully, I also create all this to make, well, I created all my books to make my teaching job easier. So I love it when faculty show up for these things. Awesome. So, and just so you know, Shannon and any faculty and anyone listening, all of the forms I have are that you download from my site, the on the books webpage on therapythatworksinstitute.com. You can edit those forms and you just need to open the developer tab in Word, which you do differently on a PC versus a Mac, so Google it. But none of them have passwords, so you can change and make it perfect for your students. That's your tip for showing up. Thank you. I love it when faculty show up. So, why using theoretical language is key. So here's what I'm going to say. This is hard work that we do, right? People come in, they tell their stories, there's a lot going on. We are all doing psychotherapy at a time in history where our cases are more complex than ever, right? People are more stressed and distressed, and the workloads are just heavier because per hour we're having to do a lot more. And our basic tool in this field are our psychotherapeutic theories. I mean, that is our tool. And so using treatment planning language that draws from our theoretical language, it's our toolbox helps us really be less stressed and less overwhelmed when we're working with clients. And so I really encourage you to, whenever, wherever you can, and if you have any of my textbooks, if you're listening to your counseling, so I have a whole set of counseling textbooks and MFT books, to use theoretical language as much as you can, especially before you take your licensing exam, because you will find that that really does help you pass those exams. But it helps you conceptualize. It helps you be a better clinician because you develop this laser focus on what the core dynamic is. And when you know what the core dynamic is, it doesn't matter whether they're talking about work, their family of origin, their current partner, their kids, their friends. You're going to see that dynamic repeat and repeat and repeat. And when you get it's like you finally got your finger on the pulse. I actually don't care what my clients come in and talk about because if I have that core dynamic down on whatever they're talking about. If I have correctly conceptualized and assessed their core dynamic, it all goes back to these basic patterns. And so I'm always working on it, and it really creates a much more fluid relationship where clients really feel heard and understand. I'm very responsive. Whatever's on their mind, I'm able to talk about in a meaningful way and move treatment forward, whatever they bring to session, whatever the problem of the week is, we're moving forward. And your job is going to feel so much easier when you're able to identify some of these core dynamics.